Hello, I'm Mally Shansfeld, Managing Editor of Endodontic Practice US, a MedMark publication. Welcome to an educational presentation and question and answer with Dr. Judy McIntyre. In our webinar today, we will be discussing unique diagnostic cases where CBCT played a pivotal role in how the treatment plan was managed. Before we get started, I'd like to invite viewers to use the question and answer box to ask any questions, and they'll be answered at the end of the session as time permits. Now, I'm pleased to introduce our speaker. Dr. Judy McIntyre is an experienced dental trauma as a young child. Despite this, she had positive experiences at the dentist, and her passion to become a dentist developed. She attended the Harvard School of Dental Medicine, where she performed research on dental unit waterline biofilms. After graduation, Dr. McIntyre attended the University of North Carolina at Chapel Hill for her endodontic residency. Alongside renowned researchers in the field of endodontics, traumatology, and pediatric dentistry, her thesis and research regarding traumatic dental injuries have been published in numerous professional journals. Dr. McIntyre opened her own office in 2016 and has been active in organized dentistry. She's passionate about sharing her love for dentistry, trauma, radiology, imaging, and endodontics. Thank you so much for joining us, Dr. McIntyre. I turn over the webinar to you to learn more about our topic for today.
Thank you so much for having me. Today, I'm excited to share my presentation about cracked teeth, specifically focusing on the diagnosis and management and how CBCT can change your practice regarding cracked teeth. First, thank you to Dexis Imaging and my imaging specialist, Ryan Zager, for hosting this webinar. Before we get into it, if anyone wants to contact me, I am very responsive on social media. My Instagram handle is at Dr. Judy Endo, and my email is there as well. Feel free to reach out. Without further ado, these are some fractures and cracks on CBCT images. And when I opened my own practice and purchased my 3D CBCT unit, I expected to see cracks and fractures with images just like these. Unfortunately, these are rarely the images that will be shown when you take a CBCT image. In these images that I'm sharing on the screen, you can see that there's significant separation. So the CBCT scan is going to capture that, and that's what's going to be conveyed. However, a lot of fractures and cracked teeth don't show images like this, no matter the CBCT unit you have. It's just the amount of separation. So today, I would like to show you and share several cases where CBCT has been helpful and definitive regarding how to proceed with cracked and fractured teeth. In other words, how CBCT and my diagnostics has helped me diagnose a crack or a fracture, and then from that information, which ones both the patient, the restorating dentist, and I want to focus on saving. So here is a case where, again, it showed significant separation, but I'd like to show you in all three axial, sagittal, and coronal planes that you can see that the separation is on all three planes, right? The separation, the crack, the fracture goes through this entire root buccal lingually. You can see the vertical root fracture also extends longitudinally here as well as here. And again, these are rare. They're so rare that I'd like to share with you a case to illustrate this example. This was a case that was referred to me. Now, I've been practicing for 2 decades now. I was trained with periapical images, 2D x-rays, and from that, I was trained to do endodontics and save teeth. So of course, let's start with a 2D image. Here you can see a periapical image, and I always like to look at the crowns first. So we have some medium-sized restorations, nothing very impressive for sure, maybe some recurrent decay, some pulp stones, and I always also like to follow the horizontal bone levels. And while this looks quite contiguous and quite even horizontally, I want to say that really it looks less dense horizontally here, a little bit. And of course, there's a periapical lucency in this upper left second molar. To be very honest, depending on all of my other diagnostics, I would probably do this root canal, especially given all of my training. And possibly when I entered this tooth, I would have realized that something was different about this case, but that's why I rely on 3D imaging. So this was the referring dentist's PA, and this was the 3D scan that I took in my office. Now again, this is very impressive. And again, this is rare, but you can see here very clearly that this second molar has a longitudinal crack. There's not only a periapical lucency, but there's a lucency where the crack ends, understandably, and there's also a horizontal crack in this mesiobuccal root that extends through the entire mesiobuccal and distobuccal root. All of this in the axial is bone loss because of that fracture. So this tooth is almost kind of barely hanging in there because it's been fractured. What I also like to gather from this image is that this periapical lucency is also communicating with the sinus. The sinus should be black, black like this background, and this is all filled. This patient sounds nasally because of this sinusitis that's basically due to a lesion of endodontic origin, a lesion of dental origin. This tooth cannot be saved. And while my diagnostics are very good, this 2D image would have never conveyed the extent of destruction that this 3D image really shares, not just with me, but with the patient and also with my referring dentist. All three of us know and can sleep well at night knowing that we've advised this patient with the utmost information. When patients come and I review their scans with them, they might not really understand what we're sharing with them on 2D. But when they see themselves in 3D, they really do take it home and understand what we're trying to convey to them, and they understand why this tooth can't be saved. So let's back up a little bit. Obviously, I'm an endodontist. So even yesterday, I was referred to patients with extreme pain. One of them had a crack. So how do I proceed regarding what teeth can be saved or not? So any patient coming to me in pain or not, I always have to start with a diagnosis, right? And how do I come up with a diagnosis? Well, first I'd like to look at the patient clinically. That means with our eyeballs, right? And that also means probing and maybe also testing with an electronic pulp tester. If my cold test seems to be unreliable, I'm percussing, I'm palpating, I'm measuring around the entire tooth, just like your hygienists do. And more recently, I have started transilluminating almost every case that comes in. Transillumination is not a new test, but it's a test that I'm relying more and more on because just like this picture shows, a lot of our patients' teeth have these amalgams, right? And have these craze lines, right? Extending distally, buccally, palatally. And sometimes we can get an explorer to catch in on a marginal ridge, and sometimes the explorer won't catch at all, for example, like perhaps on this palatal craze line. But the transillumination is going to show me the extent of the cracks within the crown. And I'll touch more upon this later. So if you're not using transillumination, I would highly encourage you to start. And again, I'll go into this a little bit further as we go on. So clinically and diagnostically with my pulp vitality tests, and then also radiographically, I want to see what your 2D image is. And if you don't have a recent one, I'm gonna take my own. But in the past few years, I have come to rely almost 100% of the time on all of my patients, a 3D scan. And this is the current DEXIS CBCT unit. Now, this isn't just the world according to Dr. Judy McIntyre. There's actually AAE, the American Association of Endodontists, as well as the AAOMR, American Association of Oral and Maxillofacial Radiologists, put out a joint position statement that have 12 recommendations regarding when to take a CBCT. And remember, I am an endodontist, so I am taking them on nearly all of my patients. Specifically in this joint position statement, the 12th recommendation is a recommendation for employing 3D scans to rule out vertical root fractures. So again, your patients, they come to me. A lot of them, again, look like this, right? So the Explorer catches mesially and distally, and you can see that the saliva is even like foaming inside this ridge crack / craze line. And you know, probably I would say more than half of our patients have these old, kind of uncarved, unpolished, leaking amalgams. And basically, what I'm finding is, especially, not so much in this case, but especially when the patient has high cusps, these amalgams are acting forcefully. And the more clenching, the more grinding, the more chewing, and depending on how they intercuspate and how their occlusion fits together, these amalgams have now been there for so many decades and are leaking that they're actually causing these cuspal fractures and leakage, leading to pulp necrosis and cracks in the teeth. In that case, the patient was symptomatic, and sure enough, I went in for endodontics, and what I found was that this crack continued and propagated. One thing I also wanted to address in this picture is the massive amounts of liner, right, under this amalgam. So remember that liner, because I know all of our favorite course in dental school is dental materials. So that liner doesn't have the same flexural strength. So when we put massive amounts of liner under any restoration, the more use after that tooth is restored doesn't have the same flexural or strength or integrity. And the more thick your liner is placed, the more that tooth is going to flex underneath. So sure enough, in that case, we took a scan, and it was this lower first molar. And as you can see on the 3D scan, so again, I look at the horizontal bone levels, and you can see we mostly want to have a straight line. Now, this one dips a little bit, but surely you would all agree that it's not very impressive. And for that reason, we chose to go ahead and save the tooth. This is bread and butter endo, and we can totally save this tooth. He has long roots, and after this tooth is crowned, despite these cracks and craze lines that seem so scary to our eyes, only with the 3D scan information and knowing that his horizontal bone has not been affected, this is not a significant angular defect. I can then proceed to recommend, let's do the root canal. We can save your tooth together with the restorative dentist and a crown. Now, it might be a little bit guarded, and the crack may continue to propagate, but surely this patient would get several years further out of the lifetime of this tooth. And you can see that here is the root canal. And with all of my root canals, I seal the gutta percha over so that there's no leakage, just in case the temporary comes out or anything else. And again, you can see on 2D that his horizontal bone is quite uniform. When I decided to commit myself to getting better on 3D interpretation, I also inevitably got better on 2D interpretation. So I really do look closely at all aspects of the films that my referring dentists send, as well as the films that we take in our office. So one thing I'll want to point out to you at this point is see how here it's all dense, it's uniformly dense, and here is actually two different bone levels. So I'm going to notice these little discrepancies in the bone to make sure on the scan there's no angular defect there. And what we always want to see on the scan is just like with 2D images, the tight PDL and lamina dura, and then bones surrounding each of the roots, right? So see how the PDL here hugs each of the root surfaces in the axial, and that's what we want to see. Speaking of 2D films, I would like to encourage you guys to always try to take meaningful 2D films. So this was a case where I was sent this patient who had pain in their upper right quadrant. So while I do appreciate that this captured the roots, because not always do I get PAs that capture the roots, this is a very, very, very distally angulated film. There's so much overlap on from each root onto the next that really it's barely diagnostic, unfortunately. So remember our Dexter days where the x-rays should be going through the contacts of each of the teeth, because this was clearly not an aligned Dexter day, and for that reason, it's barely diagnostic. However, there are a few things that I can glean from this x-ray, and again, I would like to share that with you so that you know how critically you should be looking at your 2D to be more suspicious of things that should be noted or suspicious findings. So again, I'm going to look at the horizontal bone here, 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 and it all of a sudden dips right here. See that little dip on tooth number 5, the upper right first premolar? And also, I would say that that premolar has a little bit of widened PDL. Sure enough, when we took the scan, and remember, this is a virgin tooth, so very, very, very incredulous, right? Canine, horizontal, it dips. So I would call that a small angular defect. And then on the distal, the bone should go like here. So this is a bigger angular defect than the mesial. And then again, same on the distal here. His bone, he's a young guy. His bone should be horizontally across uniformly. These little V-shaped notches in the bone are angular defects. And again, widened PDL on that buccal root. So he was an anxious patient. He came for the consultation. We did the diagnostics. Sure enough, he had a small craze line, but again, virgin tooth. So I wasn't that impressed. And he was like, okay, I'm just going to wait and I'm going to talk about getting a crown with my referring dentist. So we thought, okay, let's go conservatively and get that tooth to be hugged first, and maybe his symptoms will go away, right? Because again, this is a widened PDL. I don't know that I would call this a lucency quite definitively. It's definitely widened. So he waited about 2 weeks, and I believe he did have a plan to crown the tooth. However, 2 weeks later, he became so symptomatic that he was begging to get into our office. Now, again, you can see this is not that, like, it's some staining on the marginal ridge. And I started the access, and there's maybe a small craze line. And yeah, he has a very stressful job. He admits to clenching and grinding. And so this is what I would just call a craze line. Again, not very impressive. But I went into the tooth and it was necrotic. Now again, look at this faint line distally, faint line mesially. Not impressive. Like, how can basically a small craze line cause necrosis of this tooth? But it does. And sure enough, there's my final root canal. And again, I always seal over my gutta percha. And you can see the tooth split just like on the 3D. I knew it would split, and the 3D information helps me that way too. And then my assistant also took angled films as well. This is another 2D image. And this patient had recently received a crown on tooth number 3, the upper first molar. One thing I would like to encourage you all to do whenever you're replacing a large restoration or a symptomatic medium to large restoration, and especially always when you're going to place a crown, please, please, please take a PA x-ray before you place the crown. I probably see more than I'd like upset patients with recently cemented crowns because not only do I have to drill through the crown, they often share the sentiment that they feel like they should have known. Now, we all know patients don't listen or listen to what they want to hear, but just consider taking a PA of any large restoration that you are planning to replace, and especially crowns before you place them, because oftentimes there's a lesion already there, and that doesn't make patients happy. So I would say whenever you're trying to treatment plan a larger restoration or a crown, have a PA taken within the 3 months of that restoration being replaced to be sure that there's no periapical lucencies, and also test that tooth. You don't want to marry them to something costly, um, and no matter the cost, that something that's going to become shortly symptomatic right after. So back to this patient. So this patient came for pain, and yes, we do see a periapical lucency on this upper first molar. And again, when I look carefully at this PA, again, I'm looking at the horizontal bone, I'm looking at the horizontal bone, I'm looking at the horizontal bone. And again, this is also mesially overlapped a little bit. But do you see this angular defect right here? Once again, this is a medium-sized restoration, but there's a mesial angular defect right here. This is probably a crack. And sure enough, when we looked clinically, it's not impressive for sure, but that is that craze line that's there causing that angular defect. So one thing that I like to do when I have a consultation, yes, of course, I'm focused on the tooth at hand, but I'd like to inform the patient of all of my findings and inform the general dentist so that I am somebody who, to the patient, is unbiased regarding their care, right? I'm making a recommendation not for me to do treatment, for them to seek treatment in your office for full coverage here in this case, so that this crack doesn't further propagate and so that this tooth can be saved. If this tooth continues to be used without full coverage, that crack and that angular defect will propagate and the patient will lose this tooth. On CBCT, here is the illustration of everything that I've shared. So that angular defect, the periapical lucency on that molar. And what we really like to do in my office is whenever a patient comes for a top tooth, we intentionally try to capture the opposing arch as well, because more often than not, we find incidental findings. So this patient is completely asymptomatic, but has large periapical radiolucencies attached to their lower first molar as well. This patient had a crown replaced. And again, let's focus and trace the horizontal bone, trace the horizontal bone. It looks nice and uniformly dense. And here it kind of doesn't. And then we pick it back up. She had this crown replaced, I'm not sure why. And looks like a great crown. Again, a PA was taken. And then she became symptomatic after this crown was placed. And again, this image shows a little bit better, but it's still divoting there a little bit, right? It's not as dense as on distally. Sure enough, I did the root canal, the core, and that horizontal bone. Again, we'll watch, but it's looking better. And dense horizontal bone. And what we start to notice to see is there's a small divot on this distal second molar when I took this final And that is not there on this PA. Do you all see that? Well, surely enough, 3 years later, she was sent back to me from the referring dentist to check on this first molar because she was having some biting pain. I tested the tooth, I took the scan, and of course, this tooth was fine. It was this tooth and this angular defect on the distal of the second molar that was causing her discomfort 3 years later. So again, please look very critically at everything on your 2D. This patient presented, again, virgin tooth. She actually came for another tooth, but again, I look at the entire scan and I noticed this angular defect and widened PDL here mesially as well as periapically. Here's my transillumination. Virgin tooth. But you can all see how impressive this craze line is. When you transilluminate anything, right? The light is supposed to shine through an intact object. But if there's a disruption in the object, like a crack, it's not going to shine through. So this is that tooth. And you can see that it is cracking through and through from the mesial to distal. So again, back to transillumination and what I'm saying. So again, a flashlight on my hand, right? On my finger. The light is going to propagate through my fingernail, through my whole finger. If there's a crack, for example, in this egg, right? It's going to light up, right? Where the disruption is. When there's an amalgam or a restoration and there's a disruption in the tooth, for example, here, I'm lighting up the entire tooth, but because of this cuspal fracture through and through on this distolingual cusp, only the distolingual cusp is going to light up. It's not going to let the light shine through because it's no longer intact. Same thing with this lower molar. This is called an entire it's starting to split. The entire lingual lights up, so it's splitting mesially, distally across. The buccal is separating from the lingual and vice versa. There are expensive dental transilluminators out there. I buy several of these. I have them in each operatory. And all I do is I put an X-ray sensor barrier over these so that I can shine the light on the patient's tooth. I give them a mirror to look with me so that they can see exactly what I'm trying to convey in terms of their fractures. And it is really eye-opening. So back to her case. I went in and sure enough, you can see that the crack line, the craze line propagates faintly, but it's there. And the tooth was again necrotic. These are virgin teeth, remember. And there's the root canal. Now let's progress a little bit. So on my CBCT scan, so different case here, this patient came and the CBCT showed a deeper angular defect. Now, this is the sagittal, this is the coronal, and you can see that the bone in between teeth should be uniformly across on the coronal, okay? Here, it divots because that's corresponding to that defect. Again, on the axial, bone, 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 shadow. And that shadow corresponds right to here as well. So they look like Mickey Mouse black ears because there's no bone there in the axial. You should see PDL and bone surrounding the entire root of the tooth when you're properly aligned. And to summarize, there you go. So we decided to do a root canal on this tooth after explaining the risks and benefits with this small angular defect. Now, let's talk about lengths, right? So we're at the bone level, and this is a fairly decent average lengthed root. I would say I would save teeth given the root length from the horizontal bone levels. If you think about half of this root, right, I would say less than a quarter. So maybe 15 or 20% of the root length below the horizontal bone are the ideal cases that I am interested in saving, okay? And these patients also really need to understand that they need full coverage restoration, either immediately or coordinated in sync with the endodontic procedure. Sometimes, if there's no endodontic symptoms, because sometimes you can just have biting pain, then I'm recommending a crown like I did with that first patient. But when there's endodontic symptoms and angular defects or cracks, clinically, radiographically, we're doing endo as well as full coverage. On this patient, we incidentally also captured some decay on the opposing upper molar. And again, that is why we're intentionally capturing both arches. This patient came for, again, a very small angular defect on this lower first molar. So you see horizontal, 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 dip, horizontal, 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 okay? Again, on the axial, bone, 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 Mickey Mouse ear black, bone, 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 all right? So that corresponds exactly to the same location in all of the planes. And patients are really receptive when they see this. This patient just came back because she appreciated what I had found on this tooth as well. And the dentist had no idea that this even existed there with this amount of destruction. So this patient came and wanted to save their tooth. And if we go through this scan, you can see bone, 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 and then a big divot of an angular loss, as well as a lucency apically, right? And again, this is why I love sharing 2D in conjunction with 3D. We don't see any hint of this. And again, this is not the best 2D image, but we don't see any hint of this angular defect on this 2D image, right? And these are medium-ish restorations. They're certainly not, 5 surfaced, 3 surfaced, 4 surfaced amalgam restorations. But this is a middle-aged female, and this amalgam has been there probably 3+ decades. So again, that angular defect, you can see my orange line is oriented perfectly, and you can see bone, 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 black, and then the bone picks up. So that's what we're looking for. We're looking for discrepancies in the bone. And again, a little bit more clear, that angular defect. So once again, this is really the furthest extent, right? I would say that this might even be maybe a hint more towards 25% of the root length, right? But this is the farthest extent that I want to save. We're having serious conversations with the patient. In fact, she left. I got on the phone with the general dentist. The general dentist then had her back in the office, and there's a lot of coordination on making sure that this patient understands that this tooth may not last. This, again, this is a little bit farther, the farthest extent of teeth that I'd like to save, even with full coverage. It's a big investment that we're sharing, that we're asking of the patient. We're giving them the options of extraction, absolutely. So they're risking the expense and their time of the root canal and the crown to save this. And also, they're going to be committed to cleaning this angular defect so that it doesn't food impact and so that they can keep it clean. This bone won't regrow. That crack is there. So they have to keep that clean and keep food out of there. So again, interpreting her full scan, she has again a disruption in her sinus floor. She has fluid in the sinus, a break palatally, as well as a break apically into the sinus, and lucencies on all of the roots, okay? This is a great scan, super informative. We have a lot of work to do here. This tooth has a lot of healing to do. That crack will never heal. But with endodontics, all of this will heal. This bone will not. However, after the root canal, I'll address how I seal this up. So clinically, this was her tooth. You can see the crack, and faintly, it even goes faintly across the entire pulpal floor. Let me do that again. So big, big, big. My explorer catches here. My explorer catches a little bit here. My explorer does not catch, and I'm in the pulp now. I'm in the chamber here. Mesiobuccal, distobuccal, palatal canals, right? Faint, faint crease line, faint crease line, faint crease line, and then I'm catching again with my explorer. A few things here. So if you take your apex locator with a file, a 10 or a 15 file, and you place it on these cracks, and I'm going to do this again with another case shortly, and you place the apex locator attached to a file and you touch the craze line or crack within the pulp chamber, it might beep here. Why is it beeping? Well, because the PDL is on the other side, right? There's a communication of the craze line and the crack going through. If I hear it beep or not beep, I might change my continuing to finish the root canal. I might stop. I might inform the patient. I don't want to hear beeping here, because if I hear beeping, that means that the PDL is on the other side. If I just hear beep, 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 that means it's not through and through yet. If it flatlines, however, I'm definitely stopping. If it flatlines, that means it's through and through and that the PDL is already through. This tooth is in two separate pieces already. Now, the other thing that I'm doing when I treat these cases is this goes deep mesially. We saw that on the cone beam scan. So what I am doing is I am placing biocompatible bioceramic putty, like MTA or any type of putty, down in the chamber over my gutta percha, or for example, if this craze line were to extend like into one of the canals, I would place that putty as far apically as I see that craze line extending, because that biocompatible cement will fill in those voids and hopefully serve like as a glue to hold the tooth together. The other thing that I'm doing, again, you saw, is sealing over with flowable. And in these cases, I'm reducing the occlusion. And when the referring dentist allows me, I'm also building up the crown, the core myself. I'm doing the cores in my office so that they have less risk, right? They leave my office, they're numb, they go to chew, heaven forbid, even though I tell them not to, and they bite down on one thing and then the tooth has to come out. That's what I don't want to happen. So when I can, when I have permission, I'm also doing the core. And again, a clearer picture. So again, my explorer catches here. You can see the craze line again that goes over. And again, this did not flatline. It did not beep. And that is why we proceeded. And again, you can see in this case, I did the core. So I did the, you can see bioceramic putty, which is more dense, and then the core. And I shaved down the tooth. Now, for everybody that has come to the conclusion already that I'm completely nuts, I'm not saving these, right? So if we go to the horizontal bone and we see now that we're beyond that quarter, beyond that 20%, there's nothing that can be done for this tooth. This is straight to the oral surgeon or back to the general dentist to extract this tooth, okay? So I wanted to take a minute to establish my limits and that I don't try to save everything that walks in the door. And you can see, again, bone, 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 a little bit of whitening, bone, 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 big, huge Mickey Mouse ear, right? Like I've been showing you like little Mickey Mouse ears. This is like a whole like barnacle on the side of the distal root because this is massive bone loss, massive angular defect. This has probably been there for years. And you can see on the volume rendering here, right? Distal to this second molar is bone, right? You can see this here. And on that first molar, you can see straight down into the root and probably even that crack if I'm hallucinating right there. So when you can see down in, right? Down in, those teeth can't be saved. All right. This patient came for a consultation, had a previous root canal. And again, I told you, these are rare. You're not going to see cracks so clearly like lightning bolts with tooth separated segments very clearly. But sometimes you do, and this tooth could not be saved either. And again, mesial bone, a little less of an angular defect there. But again, I'm sharing this because of that separation, and this tooth was scheduled for extraction. This tooth, again, angular defect, a little bit closer to 50% here. So again, a little bit beyond what I like to save, Mickey Mouse ear, bone, 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 Mickey Mouse ear, which corresponds to this angular defect. And again, in the coronal, you see horizontal bone and then that exact divot. So see how my orange line corresponds? I'm at that same Mickey Mouse ear here and that same level right here. So this is that defect there. And if you were to probe, right? I know probing seems difficult and it can be, especially interproximally, but if you angle this, you're gonna get a reading. You're gonna get the 7mm reading here. And this we're not saving. Here's another example. I said I was going to show you another one. This is another example where we have no bony findings, right? We can all agree there's some good horizontal bone here, maybe a small divot here, good amount of bone, good amount of bone. But again, here, very good bone and maybe a small distal angular defect on this upper first molar. And this is what it looks like clinically. Pretty bad, right? And this did beep. This beeped, even though there were no long-term bony changes. So we had a conversation with this patient. We sat him up. We said, listen, we showed him the pictures. You know, this, we knew it was cracked, right? But it has gone through your pulpal floor. Again, I attached the file with the apex locator and it did beep. He still wanted to proceed and save it. So we did the root canal. And again, you see still good horizontal bone. So what I really want to take a moment to convey is I'm putting everything together, all together, clinically, what I see with my eyeballs, what I find with my tests, my 2D images, as well as 3D, and then informing the patient the best we can. And not every patient wants to save even the minimal ones. And the minimal ones also not always can be saved due to time or resources of the patient, and vice versa. Some of the major angular defects the patient wants to save and we can't. Again, I place flowable, temporary, reduced the occlusion, and sent him back to the dentist for full coverage. This patient had extreme pain. This patient wanted to save the tooth, but we could not, right? Shorter roots. So again, it's not just the depth of the angular defect, it's the extent from the horizontal bone to the root apex. How much root do they have left? Again, ideal is about 20% down of the root length or less, in my opinion. That's according to me, my opinion. So again, bone, 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 Mickey Mouse ear, and that corresponds to that right here on the angular defect. So this case is pretty exciting because we've been talking about cracks and fractures, and this tooth does not have a crack, but I'm sharing it for another reason. So let's look at the 2D image. So possibly we have a periapical lucency on this upper first molar. And maybe if we were to squint a little bit more, we could find some other findings as well on this 2D image. And definitely there's an angular defect here, right? So you see this is good horizontal bone, and then see how this divots. So anytime you can find like a less dense triangle on the bone, that's what you're really looking for. Now, for the people that are really squinting at this X-ray, I hope you've now picked up on one more finding, and if not, maybe two more findings. There's a lateral lucency right here. There's also a little bit of a widened PDL right here. This tooth is necrotic. These lucencies are because the tooth is necrotic. This is a lateral lucency surrounded by bone. Okay, so again, a Mickey Mouse ear, but not because of a crack, but because of necrosis. This is essentially a periapical lesion like this, but on the side of the tooth instead. And it's because there's a lateral canal in this tooth. So again, bone, bone, not a crack. This is a lateral lucency. So what is this going to look like, and how can this help you discern from cracks? Number one, we can transilluminate it, and I'm sure that the whole tooth would light up. There would not be a disruption in the light. Number two, we have a cone beam. So we see the periapical lucency, and then we very clearly see the lateral lucency. And if we squint even harder, you can see a faint kind of oblique line, which is a canal, and then another faint one right here. So this lady is just filled with lateral accessory canals, right? And when they stay dead for that long, they're going to start to leak their bacteria out into the bone at every portal of exit of the tooth, right? Teeth, I hope we all know now, don't just have one portal of exit. Most of them don't anyways. So, and again, possibly that small angular defect here that I noted on that 2D from before. So we are at this level. We are at, with this orange orientation, we are at this level of the lateral lucency, and here we can see the lateral lucency. Sometimes, not in this case, but sometimes we will see the canal with a little faint branch. If we go up to this section right here, we actually can pick it up. See this little branch right here? Little faint line, and it corresponds, see, right here to that lateral lucency. Right there, we're back, and then again, you can see this one that I picked up on right here. And if we look at this CBCT image even more closely on the bottom, she has another lateral canal right here. But again, this is a vital tooth, so no lucency. And what makes me excited to share about this fill is that when these lucencies are hydraulically condensed, either with sealer and or gutta percha, you'll pick up on these lateral canals as well. So this lateral lucency is now filled with my sealer, and hopefully this will all heal in time. So this is a case where the patient came in pain and the tooth had an angular defect. She had been to another endodontist, and that other endodontist did not use a CBCT scan and was ready to do the root canal. And to be very honest, I probably would have too, except she shared that she had already lost a tooth on the contralateral side due to fracture, and this tooth is cracked. It has an angular defect. It's definitely towards the most apical extent that I would save. But because of her previous experience, she opted for extraction. So again, back to these virgin teeth that keep on cracking and necrosing. We look at this and we see good horizontal bone, and this might be a little overlapped. Maybe there's something here, but I would say that this is pretty difficult to interpret, which is why 2D is limited. There might be a small periapical lucency here, but again, it's a virgin tooth. My referring dentist was completely incredulous, rightly so. Clinically, nothing. Maybe a small craze line here, maybe some decay, but transillumination actually showed through and through. Not very impressive. What's going on? Well, the test was necrotic. And every single time, even still, I've worked on hundreds of necrotic virgin teeth, but it still gets me because it's so mind-blowing that a virgin tooth can necrose, right? And every single time I have to enter virgin teeth, it freaks me out. So sure enough, you can see that there's a tiny, tiny, tiny craze line that extended into the pulp chamber. And this tooth was necrotic. 2 roots, 2 portals of exit. And again, not really any mind-blowing radiographic 3D or 2D findings. But yes, that periapical lucency is there. And I looked hard. I looked everywhere. I'm like, what is the cause? No real significant crack. If you're keenly looking at these 3D images, though, you can see that the tooth kind of has like a lopsided mesial wall, right? It's not completely symmetrical. And that was kind of, it's very bulbous on the mesial. Possibly that is why I chose to go in through that darkened pit and do a leveraged access. And this was my fill. Now I'm close to wrapping up almost. One thing that I would like to emphasize and focus on are J-shaped lesions, because we were probably all taught in dental school that all J-shaped lesions mean that the tooth is vertically root fractured. So this case was referred to me for retreatment of number 30. Now, yes, this is not a great 2D image. It is foreshortened, so you can't see that the crown is overlapping who knows what. And there's a widened distal PDL. There's a lucency. There's probably a separated instrument in here, as well as questionable endodontic filling material. Yes? The root canal was done abroad, and then the crown and bridge was done right after. And again, this is why I'm begging you guys to take better, more diagnostic films, because these angled films aren't helpful. The foreshortened films aren't very helpful. Again, maybe a periapical lucency here, and maybe there's a J-shaped lesion here. To be very honest, I'm not sure exactly what the referring dentist saw, because the only thing on my referral pad was retreated, right? But I'm suspicious of a J-shaped lesion. Hopefully you would be too, and I'm going to walk you through my thought processes on J-shaped lesions. With these 2D images, we can also see that there's decay on number 29. Now, she comes for a retreatment on her referral slip. However, when I ask the patient about her symptoms on this tooth, she says that she's cold sensitive. So please remember, once anyone enters a pulp chamber, even if it's not a good attempt at cleaning out the pulp chamber, that communication of temperature is disrupted, or should be disrupted, especially because we know that this treatment was done so long ago. This tooth can't be cold sensitive, okay? So we need to now listen to her chief complaint of cold sensitivity and figure out where it's coming from. Now, radiographically, there seems to be decay here on this lower second molar. And sure enough, when we test her and examine her, that lower second molar is cold sensitive. The tooth that she came for retreatment is only slightly symptomatic. She's mostly symptomatic in terms of her chief complaint on 29. And because of that bridge on 30, I can only get a 5 millimeter on the distal, right? So that is a limitation. And I know it is interproximally, especially when there's a bridge there. So my diagnoses are tooth number 29, irreversible pulpitis, and it could be reversible too. It's not terribly lingering. And for tooth number 30, previously treated with either an abscess, and it could be cracked, and it's also slightly symptomatic. With 3D imaging, however, we get a whole host of extra information. So here's that J-shaped lesion, right? Oh my gosh, it's fractured, would be anyone's conclusion. However, when I look more closely at this J-shaped lesion, I'm keen to focus on this little spicule of bone. Now, if this tooth were cracked, this spicule of bone, as I've shown you with all of the angular defects, this spicule of bone would be the first thing to go, actually, because the crack would propagate coronally, apically, and this bone would be gone. This is primary endo, secondary perio. This is essentially an apical lucency that has found the quickest way out is through the crestal bone. Endodontics can fix this. This is not a true J-shaped lesion representative of a vertical root fracture. This is a J-shaped lesion from endo-secondary perio. So again, if you were taught in dental school that all J-shaped lesions are representative of vertical root fractures, this is an example of that being incorrect. Vertical root fractures, however, can manifest with radiographic J-shaped lesions, but not all J-shaped lesions are vertical root fractures. And again, incidentally, we see this mucus retention cyst in the sinus that we can inform the patient of. And because I now know the information, I can adequately have a treatment plan. I can be confident in a treatment plan to share with her. I can say, yes, I can retreat this. This is not fractured. And sure enough, we do. So I go in and this entire bridge was grossly decayed. I bypassed the separated instrument and I medicated. I sealed it off inside because there was so much contamination, and I sent her back to her general dentist for a new, at least to take this part of the bridge off. She sealed her up from the inside, as did I when I completed. And you can see that this is going to be removed next, and that's why I sealed her up. I completed the root canal, bypassed the instrument, and you can see over time that this healed. This filled in with bone. She got the bridge removed, she got the decay removed with the restoration, and this is all filling in with bone. So without the proper information, without that 3D, we might have erroneously diagnosed this as a vertical root fracture when all it was primary endo-secondary perio. And long term, look at this bone. It's all good. This is a tooth that really didn't have a great prognosis, and in some offices might have been slated for extraction, but we were able to save it because we had that proper information. Lastly, trauma. So trauma is a little bit different with cracked teeth, right? They're not the true cracks like functional cracks, right? It's usually horizontal fractures, crown root fractures due to trauma. And again, in that joint position statement, recommendation number 11 is for the recommends CBCT in trauma cases. Now, historically, the IADT, the International Association of Dental Traumatology, has recommended angled films. So you come in, the patient, for example, in this case, on the maxilla and the mandible, right, because we have some crown fractures on the mandible, would take parallel films, 30 degrees up, 30 degrees down, both on the maxilla and the mandible. And that would be informative, right? It would tell us that there's roots retained in the maxilla. It would tell us that there's crown fractures here. But what 2D images don't tell us, even with angled radiographs like the IADT recommends, is the extent of any other concomitant injuries or alveolar fractures. So for example, yes, we know that the roots are retained here from 2D. We know that the crowns were fractured. But what we don't realize and what we can't quantify on 2D is that these lower teeth have actually been luxated, and we can measure this. This looks like a 2 millimeter luxation. That PDL has been widened by 2 millimeters. This trauma moved the teeth about 2 millimeters, and we can quantify that. Before, with 2D, we would be limited. We wouldn't be able to pick up on the extra adjacent luxation injuries solely with 2D images. We might suspect that they're luxated because they're probably sore, but we wouldn't be able to quantify. And oftentimes I see disruptions in the maxilla or mandible with jaw fractures. And then lastly, what we might be able to see as a crown fracture, with 3D, we can see the extent of it, right? So the fact that this tooth has a crown and root fracture supracrustal to the bone helps me plan for what I'm going to do next. I know that I can remove this easily. Whereas if it were more obliquely fractured, I might be involving the periodontist. I might be involving the oral surgeon. I might be involving the orthodontist to super-erupt the tooth so that we can get restoratively below the fractured segment. So all of this is helpful only with 3D imaging. And that is why I so very much value it on nearly all of my patients, especially on trauma patients too. So again, here, predictable, easy, but here you can see this is not a DEXIS, and this is not a DEXIS 3D, and this is not this case. So you can see in the maxilla here, number 8 has a crown root fracture that extends into the bone. This is going to be a whole different ballgame from this tooth. I hope that made sense. So in closing, if you have any other questions, feel free to look. I have a whole section on my Instagram page about CBCTs. I go through lots of fun cases. I also have an entire video on there from October 22nd, I believe, 2022, on how I look at an entire scan, which is hopefully helpful to you guys. And here's, again, just a sneak peek on how I go through it. I align, I look. So I'm going to rotate all of the axes through, and I go through. That's a little bit longer, so I'll skip this. And then if you're ever in the Northeast, my practice is about 30 miles west of downtown Boston. Feel free to reach out with any questions that you might have. As you can tell, I'm really passionate about saving teeth. And thank you so much for your time.
Thank you so much, Dr. McIntyre. That was a great presentation. We do have some questions coming in, but before I get to those, I'd again like to invite our viewers to use the question and answer feature in the control panel on your screen to ask any questions. The first question that's coming in: what are some important questions I can ask a patient when they come in complaining about biting discomfort?
Yeah, so for example, like yesterday with my 2 emergency patients, I go through the testing. So, quickly, I do determine if it's just biting sensitive that they're complaining about, or if they're actually temperature sensitive as well. If they're only biting sensitive, that's when I'm going to start specifically probing about diet. You'll be surprised. Like I had a one patient who was a young patient, and I had done a root canal on them, and they had come back and they were like, I'm still in pain. And this was several months after their root canal. And, I'm looking and I'm tapping and, nothing's really bothering them. And, I start asking about diet. So one of the first things that I ask when I ask about diet is, have you eaten popcorn lately? So popcorn kernels can actually, especially their husks, right, can get really dig into our gums. I'm sure we've all experienced it. So sometimes I'll see a periodontal abscess, right? And the dentist may or may not look that closely, may or may not ask the questions that I'm asking. But again, if my testing isn't adding up, that's when I start asking those questions. And sure enough, a lot of periodontal abscesses actually are just because of, nut husks or popcorn kernels or popcorn husks. So, sometimes, when there's a diet component, that's where I'm relying heavily on my clinical as well as testing, because you have to really be impressive on multiple fronts for me to want to proceed with a root canal. When there's a popcorn kernel hidden under the gums and it's manifesting like an endodontic abscess, it's usually just a periodontal abscess, and I can dig and remove that and the pain goes away. So that's when I do start specifically focusing on diet questions.
Okay, interesting. Number two, I have a patient that keeps on complaining about food trapping. What would your concerns be in that case?
Yeah, so like I shared on my presentation, when you have those, moderately advanced angular defects, even the best contoured crown is not going to prevent food from trapping in there. And that can hurt too. Like I've seen some temporary crowns and some permanent crowns where a patient keeps on food impacting, and ultimately the gingiva is going to get angry. And if if a food impaction stays there long enough, it ultimately can cause bone loss and their own angular defects. Now, when they already have the angular defects and then they proceed with the root canal and crown, it's a lifetime of cleaning. So they're going to be using those proxy brushes and floss and just really having to clean that spot well, just like with implants, right? You can't get those beautiful embrasures and bony contours and gingival scalloping back after there's bone loss.
Okay, next, how often do your hygienists take periodic PAs on crown teeth? Is it only when there's a complaint?
Yeah, so, I love this question because I actually wrote an article about this. I find this fascinating. So I think I spent probably too much time encouraging everyone when they're replacing large restorations to take a PA beforehand. And the unfortunate part of what we do is that patients are very insurance oriented, and insurance seems to dictate their care, not what we recommend, but what they want to do, right? So let's say their insurance plan covers bite wings every 2 years and FMX every 5 years, right? That means that unless really you have a very proactive staff or you intend and speak with them about replacing a restoration, you know, one might not take a PA proactively before they're replacing a large restoration or a crown. I asked one of my friends, like, hey, when you place a crown, like, do you take a new PA? And she's like, no. And this is a very experienced dentist. And she's like, no. I'm like, well, what do you rely on? She's like, the most recent PA. And I'm like, well, what's your most recent PA? She's like, whatever I have in there. And again, insurance dictates the FMXs are only 5 years. So unless you have a patient that says, okay, take that PA, you might be placing a crown from 5 years prior, from based on a PA from 4.5 years to 5 years prior, or last year. What I recommend is that anytime you're going to change a restoration, take one within a month or two of replacing that restoration. There might be a lucency there. A lot can change in 5 years on that tooth, right?
True. Um, do you cold test teeth before placing crowns or changing medium or large restorations?
So I don't place crowns, but I would highly encourage all restorative dentists to cold test teeth before they replace any medium to large restoration, and especially all crowns. Yes, very great question. Cold test always, and take that PA.
Okay, do you know how to EPT on a crown tooth?
Ooh, great. Yes. So if you have an electric pulp tester in your office, right? So people will be like, oh, I can't on this crowned tooth. So what I do is I take the wand, and I actually have a video of how to do it on my Instagram page, but I take the EPT and then I connect it to an explorer. So the wand goes to the metal explorer, and then you try to find a spot near the CEJ that you're not touching the crown and you're not touching the gingiva, and that will conduct your EPT quite accurately.
Okay, and last question, what, if anything, can be done to prevent those cracked teeth?
Yes. So obviously, advanced, we can talk about, Botox in the masseters, which a lot of dentists are getting into. But the first hand line of defense would be night guards. So, one thing that I'm advocating on my referring dentist's behalf, I will often say like, "Hey, has Dr. Smith recommended a night guard to you?" And they'll be like, "Oh, yeah, they have, but it's whatever, so expensive." And I'm like, "Yeah, but you're destroying your teeth, and that can help save you from continuing to split your teeth." When I recommend it, it's almost like they are assured that the dentist has recommended something needed, right? Because I have no incentive. I don't get a kickback from your my restorative dentist's night guards. I'm saying it because I care and they need it. And because I'm a third party, a an objective observer and caregiver, healthcare provider, I can say, yeah, you do need a night guard, and it really rings true and hits home for them. I had a patient once come and his tooth was split, and he said, "Oh, my dentist recommended a night guard like 2 years ago. Could this have prevented it?" And I'm like, yeah, and that's not great news to give. He's like, "Yeah, I didn't want to pay for it." And I'm like, I understand they're expensive. I paid for mine. It's not cheap, but certainly when faced with the loss of a tooth, it's a small price to pay.
Well, thank you everyone for your questions, but we've run out of time today. If we did not get to your question, we will answer it after the webinar via email. Within 1 hour, all registrants will be emailed a link to the replay and continuing education quiz to complete the certificate. Thank you all again for attending, and a special thank you to Dr. Judy McIntyre for the great presentation and our sponsor for this webinar, Dexis. Thank you and be well.
Thank you.